artery pressures and tricuspid regurgitation assessment. So why examine the RV? As you know, the right ventricle is affected in many cardiac diseases. RV dysfunction can be an important cause of hypotension and shock, be it in the setting of events as post-cardiac surgery, pulmonary embolism, acute RV infarction. Also, many of the congenital heart diseases involve the right ventricle, and an integrated assessment of the right ventricle is very important in rendering the proper diagnosis and care of these patients. For the adult population, there is a lot of diseases where the RV function has been shown to predict outcome, including patients with heart failure, valvular heart disease, left-sided valvular heart disease, and of course right-sided as well as different cardiomyopathic disorders. For echocardiography, we rely on 2D and 3D more recently. For the 2D, we have standard views that the sonographers acquire. They include the parasternal long axis view that gets you the RV anterior wall and is a very suitable view to obtain measurement of the proximal diameter of the RV outflow tract. It's taken from the anterior wall to the junction between the septum and the anterior aortic root. The maximum size for that dimension is 35 millimeters. In previous years, one of the criteria for diagnosing arrhythmogenic cardiomyopathy, which is a disease that involves the RV but can also involve the LV, relied on that particular measurement. As you can imagine, being a tomographic plane, it depends on whether we get into the proper plane that maximizes the size or not. Are we doing perpendicular or oblique measurements? And there can be challenges in some patients in clearly delineating that anterior wall. Having said that, when you see the anterior wall, you can also have a feel for how thick it is, though we do not measure thickness in this view. Another view is a parasternal long axis view that gets you the right ventricular outflow tract and the pulmonary artery, and you see the pulmonic valve. Very nice view to look at the distal diameter of the RV outflow tract, and the maximum size for that is 27 millimeters. Linear dimensions, unlike areas and volumes, are not indexed to body size and not necessarily different between men and women. This is in part reflecting the data that was used to generate them did not make these distinctions. But as you imagine, dimensions, just as areas and volumes, do relate to the body size of an individual. Another important view is the parasternal long axis view that gets you the right atrium, the tricuspid valve. You see the papillary muscles, the chordal apparatus, and you see the anterior wall of the right ventricle and the inferior wall of the right ventricle. We see the anterior leaflet and the posterior leaflets of the tricuspid valve. So you are able to measure the tricuspid annulus. You are able to look for tricuspid regurg, to look for pathology in these leaflets as well. This is a very important view for us. Parasternal short axis views is one of the standard short axis views we acquire. It's a basal cut, and it gets you the interatrial septum, and so you can interrogate that interatrial septum by color to look for interatrial flow through an atrial septal defect or patent foramen ovale, though we would not get good alignment with the direction of flow by Doppler. But color can show you whether there is flow or not between the two atria. You also see the tricuspid leaflets, the anterior leaflet and the septal leaflet. You can look for tricuspid regurg. You can align with the tricuspid regurgitation by continuous wave Doppler. And likewise, you can appreciate the RV outflow tract, the distal diameter here. The proximal diameter of the RV outflow tract can also be obtained in the para-short axis view from the anterior wall to the aortic valve, anterior wall of the right ventricle. We can also acquire parasternal short axis view with the bifurcation of the pulmonary artery, very useful in cases with congenital heart disease and can be suitable also for aligning with flows in the RV outflow tract as well as the distal RVOT diameter. Short axis views at the level of the mitral valve and papillary muscle will show you the left ventricle and the cross section of the right ventricle being crescent shaped, and you can see the different walls. Word of caution, this is not a very reproducible measurement, so to speak, if you were to rely on that for size of the ventricle. It's more of a general sense, but to draw reliable conclusions about ventricular size, you need the apical views. You are all familiar with the standard apical four-chamber view, and this is a view that is used to measure right ventricular dimensions, minor and long axis dimensions. But the most important view is a focused view that gets you the RV lateral wall, free wall. This is a very important view that shows you the right ventricle free wall, and this is the view that is used to look at RV volumes by 3D, as we will cover later on. A modified apical four-chamber view can also show you the lateral wall, so you can appreciate the presence of abnormalities in the lateral wall. Again, in cases of arrhythmogenic cardiomyopathy, you can have segmental dysfunction with thinning and even any localized aneurysmal formation. As you notice, it's an oblique view, and so it is not a reliable view to look at sizes of the right ventricle or the right atrium. An apical five-chamber view can be obtained, and this is the view that would show you the moderator band as you see here. You see more of the anterolateral free wall of the right ventricle. If you're interested in the posterolateral wall, there is the apical coronary sinus view, so-called because it allows you to visualize the coronary sinus clearly. Leaving the apical views and the parasternal views, there are some patients where the only views that are feasible are the subcostal views. And in these views, it is possible to look at the RV and the RA. You look at the interatrial septum. You can look for tricuspid regurg. You measure the RV free wall thickness. But they are not reliable for conclusions about the RA and the RV sizes, except in a very, very general sense. Also, if you have a patient with pericardial effusion tamponade, this is a very useful view to look at the behavior of the right ventricle. The same as the parasternal views, these are useful views also for the RV free wall assessment in patients with cardiac tamponade. It is possible to get a subcostal short axis view, and in that view you can get the pulmonary artery, you get the pulmonic valve, the distal RVOT diameter, and flow through the pulmonary artery. So remember, in patients with parasternal views being challenging, go to the subcostal views and work to get that short axis to visualize RVOT flow and sample it. Quick comments about the blood supply of the right ventricle. The right ventricle gets its main blood supply from the right coronary artery from its different branches, but there is a section of the distal right ventricle that gets its blood supply from the left anterior descending coronary artery. The same goes for the moderator band and the distal interventricular septum. Sometimes the mid-septum also gets its supply. Mid-inferior septum gets its supply from the left anterior descending coronary artery as well. The anterior wall of the right ventricle gets its supply from the acute marginal branch, whereas the inferior wall and the basal and part of the mid-interventricular septum, this is inferior septum that we are talking about, gets its supply from the posterior descending branch of the right coronary artery. The conus branch, which luckily you would not cannulate ever, gives the supply to the RV outflow tract. Free wall of the right ventricle gets its supply from the acute marginal branch. When you're looking at patients with coronary artery disease and RV segmental dysfunction, paying attention to which segments are affected can allow you to draw reasonable inferences about which vessel is diseased. Now let us talk about the RV wall thickness. One of the responses of right ventricle, or as similar to the left ventricle, is with increased afterload, the RV free wall thickness increases. And the reliable view to measure RV free wall thickness is the subcostal view. And it is either obtained by 2D or by M-mode, and you need to identify end diastole clearly. The upper limit of normal is 5 millimeters. There is very limited data to say what is the lower limits of normal. Some comments about the RV wall thickness measurements. You do not want to include trabeculations, papillary muscle. You do not want to include epicardial fat either. Otherwise, there will be overestimation of the wall thickness. Sometimes there are challenges because of oblique views in the accuracy of this measurement, and sometimes when there is thickening of the visceral pericardium, also RV free wall thickness measurement may not be accurate. How about right ventricular size? We will use this to make comments about the RV and also the RA. So in the apical views, and we talked about the four-chamber view and the RV-focused view, we want to measure the diameter of the right ventricle. This is a transverse diameter at end diastole for the basal third of the ventricle. You can also measure the long axis of the right ventricle. You can measure another minor dimension. It's a transverse dimension, halfway between that basal dimension and the RV apex, about the level of the papillary muscle. The upper limit of normal for dimension 1 is 41 millimeters. This is irrespective of size or sex, and for the middle dimension, it is 35 millimeters. For the long axis, it is 83 millimeters. Similarly, in that view, you can look at the right atrium and you can measure its minor dimension from the lateral wall to the interatrial septum. It is typically measured midway in the right atrium, so halfway between the apex and the tricuspid annular plane. The normal value is about 44 millimeters. You can measure the long axis of the right atrium from this roof to the tricuspid annular plane, and the upper limits of normal there is 53 millimeters. You can also planimeter the right atrial area, and similar to the left atrium, the maximum size is at the end of systole before the tricuspid valve opens. The upper limit of normal here is 18 centimeters squared. Let's talk about areas and fractional area change. First, when we talk about the area of the right ventricle, we can measure that area at end diastole and at end systole. The way we trace the area is we start at the lateral tricuspid side of the annulus. So you can say the lateral corner of the tricuspid annulus. You go along the RV free wall. You want to visualize the apex and go all the way to the apex, and then you slide along the interventricular septum to the medial corner. As you see here, trabeculations, papillary muscle are part of the cavity. You do that at end diastole and end systole. The difference between end diastolic area and end systolic area divided by the end diastolic area is what we call the fractional area change. The lower limits of normal is 35%. And here you have an example of it. Clearly normal, a lower limits of normal, and something that is markedly compromised. Perhaps the fractional area change catches your eye the easiest, but compared to the linear dimensions, as you see, it involves more tracing, so could be less reproducible and perhaps less feasible depending on the scans. I also would urge you to pay attention as to whether the size of the ventricle and the position of the right ventricle has changed or not. Why is that important? It is important because sometimes, because of ventricular rotation, the end diastolic plane may be different from the end systolic plane. The maximum size for the end diastolic area for men is 12.6 centimeter per meter squared, and for women is 11.5 centimeter squared per meter squared. For the end systolic area, the maximum size for men is 7.4 centimeters squared per meter squared, and for women it is 6.4 centimeters squared per meter squared. The fractional area change has been compared with RV ejection fraction obtained by radionuclide angiography and was shown to have a good correlation. Again, the caveat, these are cases where you see the endocardium well and you are able to visualize the apex reasonably well. How about other indices of RV systolic function? One of these indices is the rate of rise of pressure during systole, dP/dt, and it is handled in a similar way to the approach we use for mitral regurgitation. I will start by saying that this could be used more for qualitative purposes, research purposes, rather than day-to-day actual measurements. In fact, the guidelines do not advocate strongly for this measurement. The way you obtain it is you need to compare the time interval between two velocities, one that corresponds to 1 meter per second, and if we do the modified Bernoulli equation, that corresponds to 4 millimeter mercury. The other one is 2 meters per second, and again, by the modified Bernoulli, this corresponds to 16 millimeters mercury. So the numerator is fixed at 12, and you divide that by the time interval. It is in milliseconds, so you need to convert it to seconds to come up with this value. Putting aside dP/dt, it's an interesting concept. Let us look at another metric. This metric is the myocardial performance index, also referred to as the Tei Index, and is actually included in the chamber quantification guidelines in 2015, not just the RV guidelines from 2010. The idea is that a ventricle that is diseased will spend longer time during the isovolumic contraction period and the isovolumic relaxation period relative to ejection. And so how do we calculate that? Unlike the left ventricle, flow through the RV outflow tract is obtained in the parasternal short axis views or long axis views that get you the pulmonic valve and the pulmonary artery, as you saw earlier. But these time intervals that encompass the isovolumic contraction and isovolumic relaxation, you need them from tricuspid inflow in the apical views. And hence the importance of paying attention to the RR intervals and trying to match these. If we calculate the time between the end of a velocity of one cardiac cycle and the onset of tricuspid E velocity of the second cardiac cycle, this has these 3 time intervals. You subtract from that total time interval the ejection time, which you record from the RV outflow tract, then you end up in the numerator with isovolumic contraction time and relaxation time divided by ejection time. This is by pulse wave Doppler. Another approach is to look at the tricuspid regurg duration, because tricuspid regurg includes flow from the right ventricle to the right atrium during isovolumic contraction, ejection, and isovolumic relaxation. If you get that total duration of TR and you subtract from it the ejection time, you end up with the same numerator value. The normal cutoff is less than 0.43. So if you have a ratio that exceeds 0.43 by Doppler, standard Doppler, as opposed to tissue Doppler, that's considered abnormal. One caveat for relying on the myocardial performance index, as you see in the numerator, it includes the isovolumic relaxation time. And so a patient with a high right atrial pressure, but still with RV systolic dysfunction, can have a short isovolumic relaxation time and a small value. So that can lead to misguided conclusions about RV function. Because it involves multiple measurements, and you can see it is rather tedious, and I have to look for RR intervals matching, this approach is not really used by most labs, perhaps mostly used for research. Another approach is from one cardiac cycle now, we record tissue Doppler at the lateral side of the tricuspid annulus. And here you notice the isovolumic contraction signal, the systolic ejection signal, and the isovolumic relaxation signal. If we get that total time interval, we subtract from it the duration of the systolic ejection velocity. We end up with the sum of isovolumic contraction and isovolumic relaxation divided by ejection time. A value here that exceeds 0.54 is indicative of RV disease, similar to the conventional isovolumic relaxation time that you get by pulse wave Doppler. The isovolumic relaxation time by tissue Doppler is also affected by right atrial pressure. A high right atrial pressure will shorten this time interval. How about other indices? One of the other indices that we do routinely, and we do it for all cases, and I would encourage you, if you have good recordings, to include it in the report, is the tricuspid annular plane systolic excursion. You have to align the cursor with the annular motion, and you use M mode, and you can measure that distance. A value that is less than 17 millimeters is considered abnormal. The problem with relying on TAPSE comes from two aspects, or three aspects we can say. One problem is, are we aligned indeed correctly with the annular plane motion? The second one, it's a single value, it's a single measurement. As you can imagine, the RV is changing its volume not simply by shortening from diastole to systole, but by other movement in other plane. Thirdly, this motion is affected by translation, and you can see over and underestimation of ventricular function by TAPSE. So be careful. Other measurements that can be looked at that also reflect tricuspid annular systolic motion is the systolic velocity, which you can record by pulse wave Doppler or by color Doppler. Nowadays, we do not use color Doppler. The main advantage of using color Doppler is if you wanted to compare velocities in two regions of the ventricle in the same cardiac cycle, you can do that. As you see, this is post-acquisition analysis, takes longer time. The upper limits, the lower limits of normal here is 6 centimeters per second. On the other hand, the spectral Doppler, pulse wave Doppler for the S prime velocity, the lower limits of normal is 9.5 centimeters per second. All the limitations of TAPSE apply here as well. Now that we've talked about systolic motion, let's talk about something that overcomes the issue of systolic motion and the effect of tethering of one segment on another. To circumvent these problems, these strain and strain rate were introduced. First, they were introduced by tissue Doppler. Tissue Doppler is a very tedious approach. It requires individual walls measurements, so you achieve a pretty high frame rate, but in general provides decent accuracy in terms of correlation between strain by echocardiography against sonomicrometry as the gold standard. This is one of the validation studies that relied on tissue Doppler. Notice that the rate of strain is strain rate. Strain rate is a better index of contractility as opposed to strain, but as you notice in the signal, it is more noisy. And so it is not usually utilized and is not recommended. The recommendation is strain. I would also draw your attention to this Bland-Altman plot, which shows you, even though this is probably one of the best settings as opposed to human studies, there is still a wide interval if you consider the mean and 2 standard deviation and the mean -2 standard deviation, from plus 8% to close to -6% or so. So pretty wide range. Nowadays, we measure strain not by tissue Doppler, but by speckle tracking. In the older days, the software that was used to measure LV strain was relied upon to measure RV strain. Nowadays, there is dedicated software to measure RV strain, and they can be performed on the ultrasound system by the sonographer and presented for the physician to review and report. Similar to the concept of global strain on the left ventricle, the concept of global strain was used on the right ventricle. It includes 3 segments on the interventricular septum and 3 segments on the RV free wall. The disadvantage of relying on the interventricular septum is its dependence on LV function. And so if you wanted a more pure metric of RV function, you want to look at the RV free wall. And if you have a value higher than 20, so we're looking at absolute values here, that's the better the function. There are numerous studies that looked at RV free wall strain and related it to outcome in patients with different diseases as pulmonary embolism, patients with group 1 pulmonary hypertension, myocardial infarction, patients with RV arrhythmogenic cardiomyopathy, cardiac amyloidosis, RV function or predicting RV function after LVAD implantation, and increasingly we include it in our report when we have the suitable images and the data that we trust. How about RV volumes by 3D? This is another important development, and most ultrasound systems will allow you to perform 3D measurements of RV volumes and report them when it is satisfactory. We start with the RV focused view, and then we rely on different cuts, mostly in the short axis, and looking at the RV in the 4-chamber view and coronal views, and the end product is the complete RV. So you have the tricuspid annular plane, you have the inlet part of the RV, you see the apex, the septum, and you end with the RV outflow tract. With that, several studies have published the upper limits of normal for RV volumes and diastole and systole, as well as ejection fraction. If you want to remember one number, the upper limits or the lower limits of a normal ejection fraction is at 45%. Less than that is abnormal. For RV volumes, the upper limits of a normal RV end diastolic volume for men is 87 milliliter per meter squared. For women, it's 74. If you look at end systolic volume, for men, it's 44 milliliter per meter squared, and for women, it is 36. The software that is available on the systems will provide you with these values as well, and the physician needs to put things in perspective. How does the RV stroke volume compare with the LV stroke volume, with the Doppler stroke volume, say in a patient who has a normal function with no valvular lesions? All of these should be normal and could work to provide consistency and confidence in the measurements you're getting by 3D. This is a quick list of some of the normal values that we've been talking about, and I'll go quickly through them. For the basal diameter, remember this is the one that we got from that focused view, the basal 1/3 of the RV, the upper limits of normal is 4.1 millimeter. The wall thickness should be less than 5 millimeter. The parasternal short axis diameter for the RV outflow tract should not exceed 2.7 centimeters. For the proximal diameter, which you can get from the paralong as well as the parashort view at the aortic valve level, is at 3.5 centimeters. The RA long axis diameter should not exceed 5.3. For the minor diameter, it's at 4.4. The end systolic area is 18. TAPSE is abnormal if less than 17 millimeter. S prime is abnormal if less than 9.5 centimeters per second. The myocardial performance index by pulse Doppler is abnormal if it exceeds 0.43, by tissue Doppler if it exceeds 0.54. Fractional area change is abnormal if it is less than 35%. Some quick comments about diastolic function of the RV. You can look at the E to A ratio. A value less than 0.8 or more than 2 is abnormal, but remember that the tricuspid inflow, similar to the mitral inflow, varies with age as well as with loading conditions, and so should not be used in isolation without other indices. An E to E prime ratio more than 6 on the tricuspid side is abnormal. For E prime, a value less than 7.8 is recognized as abnormal in the 2015 guidelines. But again, E prime, similar to mitral E prime, depends on age, and in normal individuals is dependent on preload. Deceleration time of the tricuspid peak E velocity could be measured, and a less than 119 millisecond or more than 242 milliseconds are recognized as abnormal in the 2015 guidelines. How about RA volumes? We tend to measure RA volumes more than we measure RA dimensions, and these give a better reflection of the right atrium, as you imagine, than a single dimension. Unlike the LA, where you have biplane, you only have the apical four-chamber view to rely upon. And by 2D, the upper limits of normal for the RA and systolic volume index is 39 milliliter per meter squared. For women, it is 33 milliliter per meter squared. Important to remember these values and consider them when you write your conclusion about RA size in the report. So we talked about the RA, the RV, the size and the function, systolic and diastolic, albeit briefly. Let's talk about pulmonary hypertension. Pulmonary hypertension is defined based on mean PA pressure, not PA systolic pressure. Initially, it was 25. More recently, the upper limit of normal is 20 millimeters mercury. If we are talking about patients with pulmonary arterial hypertension or group 1 pulmonary arterial hypertension, pulmonary hypertension should be present, but left ventricular filling pressures should be normal. Ideally, if you can measure, you want to measure LV EDP. There can be challenges with the accurate measurements of wedge pressure in these patients. Besides the LV EDP is the direct measurement of LV diastolic pressure. Also increased pulmonary vascular resistance. If we define the goals of echocardiography in a patient who's referred with the diagnosis of pulmonary hypertension, we can say these goals fall under 3 big titles. The first one is the estimation of PA pressure, and we'll talk about how we can estimate all these components. Secondly, you want to provide clues to the referring physician, whether this is a cardiac case of pulmonary hypertension or a non-cardiac etiology. And there can be clues, for example, evidence of congenital heart disease, significant mitral valve disease, regurg or stenosis, and HFrEF or HFpEF. And then prognostically, RV function and size as well as RA volume are important as well to predict outcomes in these patients. How do we estimate PA systolic pressure? We get tricuspid regurg by continuous wave Doppler from multiple windows. We rely on estimates of right atrial pressure, and I will cover that shortly. If you have an incomplete jet and you have a patient referred with a diagnosis of pulmonary hypertension and the physician wants the PA pressure, we have to inject agitated saline to estimate PA systolic. Also, if you give an ultrasound enhancing agent to better visualize the RV endocardium, you should go back and look at the TR velocity to look at the peak value. The good news is that in more than 90% of the patients with actual pulmonary hypertension, it is feasible to get a complete TR jet. I also want to draw your attention that there should be consistency between 2D findings and PA pressure estimates. For example, a flat septum in systole and diastole indicates the presence of pulmonary hypertension. And if you are reporting a PA systolic of 30, something is wrong, either in your assessment by 2D or in your estimation of PA systolic pressure. Example of an incomplete TR jet is shown here. This is a TR jet, and application of the modified Bernoulli equation, as was covered in the first half of this year, showing you a PA systolic of at least 52 based on a peak TR velocity of 3.6 meters per second. PA diastolic, we rely on the pulmonary regurg signal by continuous wave Doppler, which we get in the para short axis view. And remember, you can get it also in the subcostal short axis views. You need to look at estimations of RAP. Again, if you gave saline or ultrasound enhancing agents, you will get a better jet. The feasibility of PR jets being completely recorded in patients with pulmonary hypertension is more than 70%. The most important part of the signal for estimating PA diastolic pressure is the end diastolic velocity. So as you see here, this is the end diastolic velocity that we are interested in. And if we do the modified Bernoulli equation, even without adding any estimate of the RA pressure, you can say the PA diastolic is at least 16 millimeters mercury. How about mean PA pressure? So if I have an estimate of PA systolic and PA diastolic, then the mean pressure similar to the mean systemic pressure is the diastolic plus 1/3 pulse pressure. I would draw your attention that it has several measurements and so more potential for errors. It is also possible to get to the mean PA pressure based on the peak pulmonary regurg velocity, with or without adding right atrial pressure. Though it is more accurate if you add right atrial pressure. We'll see an example of that. You can also look at the acceleration time, how fast the velocity reaches its peak in the RV outflow tract. In general, an acceleration time 100 milliseconds or less goes with an increased PA pressure. Time intervals, however, are dependent on heart rate and in children vary with age. Possible to get an estimate of the mean PA pressure by using the RV minus RA mean systolic gradient from TR. So we get the peak gradient as usual, but we convert that to mean gradient and then add to it the right atrial pressure. The last approach is a regression equation that tries to convert systolic pressure to mean pressure. As you expect, the mean is less than the peak systolic pressure, and hence the slope of 0.69. This is an example of using the peak velocity of pulmonary regurgitation to estimate the mean PA pressure. So if we have a peak velocity of 3.4, even without adding any RAP, you can see that this patient has a substantial degree of pulmonary hypertension. To complement the assessment of pulmonary hypertension, we need to look at pulmonary vascular resistance. And one method called the Abbas method, validated by Drs. Abbas, Lester, and Schiller, used the peak TR velocity as a surrogate of the numerator, which you use in the PA pulmonary vascular resistance calculation. As you know, this is mean PA pressure minus wedge pressure. So to replace it by peak TR velocity, not even PA systolic pressure, is a big approximation, divided by the time velocity integral of RVOT as a surrogate of flow. Again, you do not have the diameter included here, so it's not the complete flow. This ratio, if more than 0.38, was 100% specific, but for a markedly increased pulmonary vascular resistance, more than 8 Wood units. When the ratio is less than 0.12 to 0.15, patients usually have a normal pulmonary vascular resistance. So you can see that there are extremes that we can rely upon to tease out those with major issues of pulmonary hypertension or those with normal pulmonary vascular resistance. Interestingly, a ratio more than 0.15 predicted heart failure hospitalizations and all-cause mortality in 795 patients with CAD who were enrolled in the Heart and Soul study in San Francisco VA Medical Center. So we covered pulmonary vascular resistance. We talked about PA pressures. How about RAP? We rely on the inferior vena cava, and here we look at the IVC diameter and how much it changes from expiration to inspiration. With sniffing, the diameter drops markedly, and this is a patient with a normal right atrial pressure. On the other hand, notice this individual who has a markedly dilated inferior vena cava that stays almost the same size with sniffing. This is consistent with a markedly elevated right atrial pressure. If you look at the relation between this collapse index and mean right atrial pressure, and we pay attention to patients who are not on a mechanical ventilation, so the solid circles, you see a significant association, albeit the standard error of estimate of mean right atrial pressure by this method is 4.1 millimeters mercury. On the other hand, when you look at patients on a mechanical ventilator, these are the open circles, there is no relation between the IVC collapse index and mean right atrial pressure. The take-home message from this slide is if you have a patient who is on mechanical ventilation, the collapse index is not particularly useful. Which takes us to the limitations of using or relying on the IVC as an index of right atrial pressure. It's in patients who are in respiratory distress because you want them to cooperate with you, spontaneous respiration, sniffing, and so on. Patients who are on mechanical ventilation pay more attention to the diameter, but not the collapse index. A diameter that is at most 12 millimeters is accurate in identifying patients with a right atrial pressure less than 10 millimeters mercury. This was a manuscript published in JACE many years ago by Ju and Schiller. On the other hand, a diameter more than 12 millimeter mercury in a patient on mechanical ventilation has no predictive value. Another challenge is posed are in the post-op settings when you do not have subcostal views, which led to the investigation of other indices of right atrial pressure. Similar to the mitral side, we can record tricuspid inflow. You can measure E velocity, A velocity, acceleration, deceleration time, a wave duration. You can also record hepatic venous flow, similar to recording pulmonary venous flow, and you have forward flow in systole and in diastole. There is a brief mid-systolic reversal, and then there is another reversal in late diastole due to right atrial contraction. The duration here can be measured as well, and similar to the pulmonary vein situation, the more prominent the atrial reversal, be it peak velocity or duration, the higher the right ventricular and diastolic pressure. Examples for the tricuspid inflow from patients with restrictive filling. Notice that the peak E velocity depends on flow. So you can have a high peak E velocity in the setting of, say, primary severe tricuspid regurgitation, even at a time when the right atrial pressure may not be markedly elevated. This is the correlation of tricuspid E to A ratio with mean right atrial pressure, a direct relation, but again, a standard error of estimate of 3.8, and you can see quite a range of values still corresponding to a pressure barely more than 10. How about the hepatic venous flow? This is a patient where predominant flow is in systole, forward flow from the vein to the right atrium. This is almost equal flow for systole and diastole. And one way of looking at these is to look at the peak velocity, but probably if we're talking flow, you want to entertain the time velocity integral as well. And here, similar to the pulmonary vein situation, the less the forward flow that you see happening in systole, the higher the right atrial pressure. Still with some degree of scatter, as you see, whether you use the time velocity integral or the velocities, perhaps better with the time velocity integral than if you use velocities. This is an example of this prominent atrial reversal I was talking to you, taken from a patient with pulmonary hypertension, RV enlargement, and marked increase in their RV and diastolic pressure. This is really a giant atrial reversal velocity. How about systolic reversal? This is a holosystolic reversal that you see, and it's taken from a patient with severe tricuspid regurgitation. Estimation of right atrial pressures in patients with severe TR can be challenging in many cases. We'll cover more about TR and systolic reversal later on. Some of the limitations for using the hepatic veins include pericardial compression syndromes, tricuspid valve disease, be it stenosis or regurg, arrhythmias is AV block and tachycardia, heart transplant recipients, and again, absence of subcostal view. which led to looking at other indices. And other indices came the tissue Doppler velocities. You are all familiar with the ejection velocity here. This is isovolumic contraction. This is the isovolumic relaxation time, and E prime and A prime. E prime is a metric of RV relaxation, and the isovolumic relaxation time is the time interval between the end of the ejection velocity and the onset of E prime. This time interval is shorter when the RAP is increased. Similar to the mitral E to E prime ratio, there is also the tricuspid mitral E to tricuspid annular E prime ratio. A here stands for the annulus. However, since EA is also a symbol for elastance, the preference now is to use E prime as opposed to EA. These are data showing the relation between the E to E prime ratio tricuspid side to right atrial pressure in 62 patients. Many of them were with cardiac disease. Several were on mechanical ventilation. Again, you can appreciate that there is indeed a wide confidence interval on the Bland-Altman plot. This is another study, not from our group, but from a Japanese group that took patients with pulmonary arterial hypertension. You see an R squared of 0.64, so an R of 0.8, and very decent correlation. Importantly, when you look at prediction of outcome here, survival, free from cardiac events, survival is much worse if this ratio was more than 6.8 as opposed to less than 6.8, albeit a small number of patients. Challenges for relying on E to E prime, or the limitations, are in pericardial compression syndromes, patients with tricuspid valve disease, arrhythmias, and absence of apical views. If I were to put a summary, I can say when you have an IVC collapse that is at least 50% and hepatic vein systolic velocity more than diastolic velocity, that's a normal pressure, 0 to 5. 5 to 10 if you have a collapse that is also at least 50% but equal, systolic equal to diastolic velocity, and you want to average multiple beats or rely on end expiratory signals. If the collapse is less than 50% with diastolic more than systolic, that's a 10 to 15 more than 20 millimeters mercury, or at least 20 millimeters mercury, less than 50% collapse, and you see forward flow only in diastole. We are getting into restrictive RV filling in these cases. Example from a patient with pulmonary hypertension, ulterior hypertension, markedly enlarged RV and RA. You see here very high peak velocity for TR, pulmonary regurg, peak velocity of 4, and diastolic velocity is a 3, and you see hepatic venous flow, predominant flow in diastole, telling you that RAP is elevated. You see this markedly enlarged RV, and one of the challenges that you get in these cases is, and when you go for apical views, it may be problematic to get a proper 4-chamber view that would allow you to appreciate the size of the left ventricle. Short axis views are important in diastole and systole to look at systolic flattening of the septum, which goes with an increased mean PA pressure, usually in these cases more than 40 millimeters of mercury. It's really a reflection of RV pressure, to be precise, as opposed to PA pressure. In the absence of pulmonary stenosis, then yes, it's a reflection of PA pressure as well. How about distinguishing cardiac from non-cardiac pulmonary hypertension? We talked about etiologies, for example, depressed EF, mitral valve disease, but how about the HFpEF group of patients? These are signals taken from a patient with pulmonary, primary pulmonary hypertension or pulmonary arterial hypertension. And typically in advanced stages, what you see is reduced stroke volume because the RV is enlarged, and systolic dysfunction. They can have tricuspid regurg, and reduced flow through the pulmonary circulation with increased pulmonary vascular resistance. So you typically see low E, higher A velocities. Septal annular velocities can be reduced because the RV systolic and diastolic functions are impaired, but if you record the lateral annulus, notice that the velocity is preserved. In this case, it's approaching 15 centimeters per second. In comparison, a patient with HFpEF or diastolic heart failure is the older terminology you see on this slide. You have an E more than an A, both septal and lateral annulus velocities reduced. We looked at the ability of the lateral E to E prime ratio to distinguish patients with primary pulmonary hypertension from those with group 2 pulmonary hypertension, and you see here a nice delineation of this latter group from group 1 patients where the E to E prime ratio on the lateral side for all cases did not exceed 6. So remember to look at the lateral E to E prime ratio when you're looking at these cases. Shifting gears to tricuspid regurg, when you think of the tricuspid regurg, similar to when thinking of the mitral regurg and the aortic regurg, look at the impact of the receiving chambers and the chambers bearing the brunt of the leak. So we look at RV size and function. We want to pay attention to RA volume. We want to scrutinize the tricuspid valve apparatus to understand the pathology of the tricuspid valve. We want to look at estimates of right atrial pressure. We look at the tricuspid inflow peak E velocity. We look at hepatic venous flow, and we look at PA pressures for clues, whether this is a secondary PR with pulmonary hypertension. 3D is very useful, and you can look at the ventricular as well as the atrial perspective. Certainly by TEE you get superior quality and is relied on for interventional procedures, a topic that will be covered by other colleagues. 2D findings we said are important. Color Doppler is important. You can look at the PISA radius at an aliasing velocity 30 to 40 centimeters per second. This is from the 2017 valve regurg guidelines by Dr. Zugby and colleagues. A radius less than 0.5 goes with mild TR, more than 0.9 severe, in between is moderate. Word of caution, you want to get a good delineation of this region and you want to sample it from multiple views. So the RV inflow, the short axis, as well as the apical views. The same comment applies for the Vena Contracta. The cutoff values are less than 0.3 and 0.7 or above, and in between is moderate. Again, you want to be able to get these decent views, which would include adjusting gain settings as well as paying attention to the aliasing velocity as you saw in the recommendations. Jet area is useful, and I will show you some recent data from our group looking at jet area. When you have a nice visualization, and when particularly the jet is central, it is a straightforward diagnosis. Less than 5 centimeters squared is considered mild, more than 10 severe, in between moderate. Vena Contracta can be obtained by 3D. For experienced operators, probably useful. For the day-to-day application, I would say more work is needed for that. Similar to the PISA calculation on the left side, we can do PISA calculation with the same principles on the right side. You can look at the ERO and the regurgitant volume. Less than 0.2 and less than 30 milliliters go with mild, severe lesions 0.4 and 45. The challenge for TR as opposed to MR, notice it's 16 cc's is enough to make someone move from mild to severe. So you want to be careful with your color Doppler settings and measurements. This shows you the application, which is straightforward as the way you apply it for the left side. Just obviously pay attention to the aliasing velocity, the radius measurement, and you need the peak velocity. And if you combine the ERO with the time velocity integral, you get the regurgitant volume. This approach, this rather simple approach of PISA, can lead to underestimation. And the magnitude of underestimation is related to the ratio of the aliasing velocity on color Doppler to the peak velocity that you get by continuous wave Doppler. And so to correct for this underestimation, there is a factor that you can multiply by, basically the peak velocity in the numerator divided by the difference between the peak velocity and aliasing velocity in the denominator. This approach was validated against echo itself by comparing tricuspid inflow against RVOT flow to get the tricuspid regurg volume, and interestingly was adopted by several publications that were relied upon in the guidelines to quantify TR severity. Again, most of the validation is echo against echo. There is nothing that looked at other measures of TR severity, in part because of the challenges in these earlier days of finding suitable alternatives for validation. One point of notion to make is there is no direct relation between peak TR velocity and TR severity. Many readers think that if the peak TR velocity is high, then TR severity is high. On the contrary, severe TR in the absence of pulmonary hypertension or a significant degree of pulmonary hypertension can be associated with peak velocities less than 2 meters per second. And for continuous wave Doppler, we want to look at the brightness of the signal and the shape of the signal. This is a faint signal from mild TR. This is an intense signal, almost the same brightness as the tricuspid inflow in diastole. And notice the early peaking, reflecting the rapid rise in the RA pressure and the rapid dissipation in the RV-RA pressure gradient during systole. Hepatic vein flow and systolic reversal, we covered that, similar to the systolic reversal that you record in the pulmonary veins. And this is the 2017 guidelines recommendation. They include relying on a number of criteria. The more of these criteria that you see, the more confident you are in your conclusion. But if you end up with intermediate values, it is best to then resort to the quantitative approaches, relying on vena contracta width, regurgitant orifice area, and regurgitant volume. And then, depending on where you stand, you place the patients in mild, moderate, and severe. Our group recently, with the help of Dr. Yang Zhan and Dr. Deepan Shah, looked at the TR severity by echocardiographic measures against CMR. And we noticed if you use CMR as the gold standard, regurgitant volume by CMR as the gold standard, which in most patients is straightforward and not challenging, all of these different indices that I presented to you have variable accuracy. But one thing stands, the systolic reversal in the hepatic veins has a decent accuracy. And notice the excellent specificity if you have a continuous wave Doppler jet that is dense and with a triangular contour. We are talking about 94 and 96% specificity. Jet area as a ratio to the total RA area during systole also was quite specific. The challenge is, are we able to record it or not? Based on the cases that we included, and we included 337 cases, 209 were mild, 67 were moderate, and 61 were severe. We came up with this hierarchical approach. And basically, my take-home message to you is if you're looking at TR, try to go to the more specific signals early on. So continuous wave Doppler, dense signals, early peaking, or a sine wave appearance. If you see systolic reversal in the hepatic veins, this is enough. You do not need to do any quantification. If you do not see systolic reversal, then pay close attention to the RV size. If you see a normal RV size, if you see an enlarged RV size with normal function, be very suspicious of significant TR. As you have less and less of these more reliable specific signals, then you tend to go into the measurements that rely on color Doppler, and here we have to pay attention to detail. I will stop here and thank you for joining me this afternoon.
Hello, I'm Dr. Alpesh Shah from Houston Methodist DeBakey Heart and Vascular Center.
And I'm Dr. William Zogby, Chief of Cardiology here at Houston Methodist. Although the pandemic prevents us from gathering in person,